Hey everyone, Dr. Kuniak here. Brief video lecture. I want to cover a brief conversation about ethical issues, particularly as they pertain to multicultural or diverse populations. Um, and then maybe a brief conversation about psychopharmacology because I want to bring that into our next live discussion. So, the Code of Ethics, without bringing it up on the screen, the Code of Ethics has, various codes that are associated with the, use of assessments, and then what we do with that data and how we diagnose. To boil it down to its most basic concepts for a short video like this, the idea is that we try to use the most appropriate assessment tools for what it is that we're trying to accomplish. And then we take that data and utilize it properly for considering diagnosis. We want to make sure that our clients are informed about how we're going to use and store the data. If it's not going to be used for research in the future, if you're trying to publish something, then they should know that it's just meant to be for the purpose of assessment and treatment planning. If you do intend to use some of the data that's being gathered for a research study in the future, then you should have an informed consent disclosure about, the idea that this data is going to be used for assessment and treatment planning, and I also may draw upon it for future publication. If a client declines, then have a backup release that just talks about assessment and treatment planning because that's all they want their data used for. But our clients need to know where that's going. And so then you should use it appropriately. Now, does every assessment tool, do we take it as, as the word on the diagnosis? No. You can use an anxiety assessment and it shows that the client is kind of profoundly anxious, and then I think it's important to discuss that then with the client to see if that fits, if that makes sense, if those results kind of align with who they are and what it is that with what they're bringing in as as presenting concerns. Maybe it does fit. Maybe they're anxious and there's a reason for it. I used to talk about it makes sense that I'm going to treat depression to try to get rid of the depression unless there's a reason that they should be depressed. And then maybe I need to help them to deal with that other reason. If they're depressed because they found out that their partner is, so if they're depressed just because they're depressed, we're going to deal with depression and like, yes, you're an important person and you deserve to be here and all of that sort of stuff. If they're depressed because they found out their partner's cheating on them, that's a different focus. And if we find out that they're depressed because of a medical condition that's going on, maybe that's leading to the depression, or maybe it's, they have some sort of, potentially terminal illness or something like that, that changes the dialogue. But we want to know where this is coming from and if it's legit or not, according to them. And you can note all of that as part of your diagnosis. So, major depressive disorder with, physical health concerns, with spousal infidelity or whatever the case may be. You can note the relation, like why this is going on as part of your diagnosis. That can get noted in your progress notes. It should probably get noted. Usually we have like treatment plans and treatment plan updates of some form, or some sort of, it depends on the structure of the agency or practice you're working at, how this stuff gets documented. um, I had at one place I worked, we had narrative assessments that came after an initial barrage of assessments were done. We would have a narrative assessment document that was kind of what it sounds like, a narrative discussion of what this case looks like, different areas of focus in the narrative, multi-page, and then we would do a discharge summary, and it was a similar, slightly shorter version of that narrative whenever we were releasing a client. And we would do monthly treatment plan updates. And so at any point, if a diagnosis changed, if we gained more information about what was going on with a person diagnostically, we could add it to any of those documents. Probably also included in the progress note that's affiliated with the session where we learned that stuff, and we move on. But so then leading into the conversation about ethical issues, and particularly as it relates to multicultural or minority and diverse populations, we don't always know what's causing a person to experience the symptoms they're experiencing. We have to rule out things like substance use first, physical health issues first, because those things could be skewing the diagnosis. It could be more about those things than it is about just experiencing the diagnosis as it is. Culture plays into it too. So, the way that a person behaves when they are depressed looks different depending on their cultural background, looks different related to their diversity. We talk about members of the LGBTQ plus population. That is an aspect of who they are culturally and diversely. Um, those individuals are at higher risk for depression and suicidal ideation than other populations because of the way that they're treated societally. So as a result, we have to note that maybe not formally maybe not formally in our diagnosis, but it is relevant. And so we want to make sure that we're not labeling someone something that becomes harmful to them. I don't know why, but we want to make sure that we're not, because of something that is completely out of their control, has nothing to do with them, and we don't want this to reflect poorly on them, and harm them in some sort of a way, you know, because of some issue that we aren't really fully assessing around or properly documenting around or properly exploring around. You may ask, like, how that could what a diagnosis could do. Now, right, wrong, or otherwise, in our state, if a person is diagnosed with profound, levels of depression, they may have their firearms taken from them. They may no longer be able to purchase firearms, go hunting, things like that. You may say that, well, that's good, and they shouldn't do that anyway. But to give you a quick example, there was a client I was working with, and again, this is not a judgment call on my part, one way or the other, but there was a client I was working with who, that was a coping method for him, was going hunting every fall with his dad. And if he was hospitalized for his depression, there was a very strong likelihood that he wasn't going to be able to do that maybe ever again, or at least maybe for the foreseeable future, depending on how that got documented and where that went. So, we want to make sure that we are uh, using appropriate diagnoses and behaving ethically to our clients. If they need the diagnosis in order to get the treatment that they need, that's also us having to behave ethically. Like, we need to make sure that we're doing the best to support our clients, no matter what that is. So again, that's boiling all of that down into just some specific talking points and all of that. And I'm happy to kind of discuss some of this more as we go. Psychopharmacology is another thing. We as counselors are not going to be able to prescribe medication. Again, right, wrong, or otherwise. We're not. That's not a part of who we are. That's not a part of our scope of practice. However, I think it's important to also not be about pushing meds away from our clients in the same way that we don't want to push meds to our clients. So I think it becomes, just like I said about ethics, multicultural, and diversity issues, we want to do what is best for our clients' interests. There have been times when I've been working with a client and they really needed to not have meds, in my opinion. Like, there were things that they could work on that would be the least harmful if they avoided medication and were, working on their needs in their life. And so becoming, um, a more rounded person with their various skill areas to manage their needs. There have been many times where I've worked with clients where meds would be beneficial and they were against it. They didn't want it. I'll share a specific story with you when we meet again. But it's important to advocate and support our clients for what is going to be best for their needs when we assess and diagnose. This client that I'm thinking of in particular was diagnosed with obsessive compulsive disorder. My diagnosis for him, and it was pretty significant and pretty significantly distressing. And so, though I could not prescribe him medication and he was against medication, I did advocate for him to be assessed by a psychiatrist. Eventually, he resisted it at first, but it was related to my diagnosis and in line with what I felt was going to be helpful for him for treatment. My fear was, and this was true, I'm not always right by any means, but my fear was that the anxiety and the panic that were associated with the obsessive compulsive diagnosis was going to prevent him from doing some of the activities that I wanted him to do to try to minimize the symptoms. And as a result, that was going to impede his ability to get through this treatment process. And that was accurate. He tried courageously. he tried to get through the activities without medication, and it was not helpful. And so we want to advocate for what's going to be best for our clients in the end, no matter what. At one time in my career, I probably had a very negative belief system around psychopharmacology because I was raised in a medically oriented family. My dad was a dentist, my mom a nurse. I had some doctors in my family at other tiers, medical doctors. And so even though they would prescribe, they were very against taking medications themselves. And so I was raised in that environment where it was you only take medications if you absolutely must, because that was the model that they were trained on and all of that. And I think that that's still the case. I think we want to do the least intense, the least impactful treatment to accomplish our goals, just because we don't want our clients to be harmed in the process or take unnecessary risks. But I have certainly reshaped my perspective on this. And if I think a medication is going to make a person um, get through their process easier, more productively, why not? Life is, in my opinion, life is too short. And if you've identified that you need to change some stuff around to live a better life, better by your standards, and be more productive and more comfortable and all that sort of stuff, and a medication is going to get you there a little bit more conveniently and comfortably while you're still working on your stuff with me as a counselor, I have no judgment towards that. I think that's great. We should do that. If you don't want to do it, that's fine. I'll work with you without it, but I reserve the right to keep it in mind if it's going to be helpful. And I've had clients who come in and that's what they want. They want a medication, and it's clear that that's not going to be helpful for them. So I advocate away from it. Um, but we have a conversation about it regardless. At the risk of rambling, or in order to resist the risk to ramble, I'm going to close up now. But I wanted to broach all of those topics with you and get you thinking about all of them. Hopefully, these little tidbits of stories are helpful for you, thinking about how we approach ethics, how we approach psychopharmacology, things like that. Look forward to seeing you again. And if you have any questions, send them my way so I can make some more of this content. Okay? Take care.